Hi friends, a very warm welcome to my YouTube channel and to this video. My name is Rajiv. I am a specialist in physical medicine and rehabilitation. In this video, I aim to present the historical perspectives of scoliosis from ancient to modern times.
I will take you through the history of scoliosis from its ancient mythological roots all the way to modern advancements like braces, conservative management, and a brief account of cutting-edge surgical techniques. This discussion will focus specifically on adolescent idiopathic scoliosis. Exploring the other types of scoliosis would require a more detailed and time-intensive approach and can be addressed in future videos.
By the end, I hope you will have a broader perspective of how this condition has evolved over time and how it is treated today.
Spinal deformity is among the earliest recognized medical conditions in human history, with evidence tracing back thousands of years to prehistoric times. It has also appeared in myths and folklore, often linked to evil or misfortune, as its visible and striking physical effects in affected individuals led people to interpret it as a form of divine punishment in ancient times. Scoliosis is a three-dimensional spinal deformity involving a lateral spine curvature of more than 10 degrees with vertebral rotation within the curve. Scoliosis can be classified as congenital, neuromuscular, syndrome-related, idiopathic, and spinal curvature due to secondary reasons.
A true scoliosis is not only a deformity in the coronal plane but also a rotational deformity.
Scoliosis typically presents with features such as rib prominence, uneven shoulders, and an asymmetrical waist. It is diagnosed using a standard posterior-anterior spinal radiograph, which reveals a lateral curvature of the spine greater than 10 degrees. Beyond the spinal curvature, scoliosis is often associated with asymmetry of the trunk and limbs. Idiopathic scoliosis accounts for approximately 80% of structural deformities in the coronal plane.
It is important to note that a clearer understanding of the present begins with a deep appreciation of the past.
History informs the now. Review the past, guide the future. It is worth noting that in the ancient world, medicine was not clearly separated from religion and mysticism. Early writings in philosophy, religion, mythology, athleticism, and folklore, dating back to ancient times, also made references to deformities of the vertebral column. Faith, divine touch, healing.
In ancient times, spinal deformities were not clearly differentiated, and scoliosis, kyphosis, and kyphoscoliosis were grouped together. While reviewing the historical perspectives of scoliosis treatment, it is essential to keep these facts in mind.
The earliest mention of curved vertebral column deformity and application of axial traction as its effective treatment can be found in the Srimad Bhagavat Mahapuranam, an ancient Hindu epic composed sometime between 3500 and 1800 BCE. Mataji Kubja is often described as having a condition similar to scoliosis, which caused her spine to curve. According to the legend, she used to supply kamsa, the villainous roller, fragrance and sandalwood paste. While she was going to Kamsa's palace one day, she was seen by Bhagavan Sri Krishna, who compassionately straightened her body by holding her feet with his foot and applying traction to her chin with his hands, symbolizing healing and grace. She was then transformed into a beautiful woman. This story is sometimes interpreted as a metaphor for inner transformation and the removal of suffering. There is a temple of Mataji Kubja known as Krishna Kubja Temple located at Mathura in Uttar Pradesh.
The story of Bhagavan Sri Krishna and Mataji Kubja can be considered as an early cultural and symbolic reference to a curved spine.
Apart from Mataji Kubja, The revered Indian epics include references to sage Ashtavakra, the great philosopher having multiple physical deformities. It seems his condition was congenital. Sage Ashtavakra is described in the revered epics Mahabharata and Ramayana as being bent in 8 parts of the body. Ashta means 8, Vakra means bend. There is strong possibility of involvement of his spine as well, resulting in scoliosis, kyphosis, or kyphoscoliosis. Despite being severely deformed, he stands as a symbol of unshakable wisdom, clarity, and the realization that the self is beyond the body. However, it is believed that later in life he is freed from his deformities after bathing in the sacred river Samanga, following his father's advice.
Sage Ashtavakra is the author of Ashtavakra Samhita, otherwise known as Ashtavakra Gita. It is noteworthy that ancient Ayurvedic texts from India mention spinal deformities resembling scoliosis.
Ancient India's Ayurvedic physicians established a remarkable legacy by developing a holistic system of medicine that emphasized disease prevention, personalized treatment including surgery, and the balance of body, mind, and spirit. Acharya Sushruta is known as the father of surgery and authored ancient Ayurvedic text Sushruta Samhita, which contains descriptions of surgical techniques and instruments. Acharya Charaka wrote the Charaka Samhita, a foundational Ayurvedic text that focuses on diagnosis, treatment, and preventive health care. Although ancient Ayurvedic texts do not explicitly identify a condition equivalent to scoliosis, the term kubja is used by the acharyas to describe a hunchbacked deformity which may encompass scoliosis, kyphosis, or kyphoscoliosis, which is a combination of both. Based on the descriptions in the Charaka Samhita, such spinal deformities can be interpreted as manifestations of Vata disorders. Furthermore, Acharya Sushruta notes that aggravation of Vata during pregnancy, Vata Kopa, may contribute to the development of Kubjada. Although ancient Ayurvedic texts do not specify particular traction methods or devices, their emphasis was on achieving proper structural alignment through external and internal therapies to reduce the imbalance of the Vata dosha. Now, let us look into other evidences of scoliosis in ancient times. Archaeological finds from ancient Egypt over 3000 years old revealed evidence of scoliosis in human skeletons. The Boxing Boys fresco from Akrotiri, dated to around 1600 BC, is often cited as one of the earliest large-scale artistic depictions that may reflect a medically recognizable spinal condition. Found on the island of Santorini, this Minoan wall painting shows two young figures engaged in boxing. One of the boys appears to have an unusual rigidity or curvature in the torso and spine. Modern interpretations suggest that this posture could represent a structural spinal deformity, possibly scoliosis, rather than simply an artistic style. Historical descriptions and artistic depictions of Alexander the Great consistently showed a tilted head, upward gaze, and slight facial unevenness. Modern analysis suggests these traits could reflect a cervical spinal deformity, possibly a mild form of scoliosis or torticollis, potentially accompanied by eye muscle irregularities rather than being purely stylistic choices by ancient artists.
Plato, the ancient philosopher, believed that having a flexible spine is a result of divine influence.
Empedocles, on the other hand, believed that the vertebral column is originally formed as a single rigid structure and later becomes divided into separate segments as a result of bodily movement, which causes the once solid bony structure to break into individual vertebrae. Aristotle studied human movement and explained muscular flexion as the process in which a straight position changes into an angled one, noting that this bending is essential for forward motion. Healing in ancient Greece took place in Asclepion, temples devoted to Asclepius, the god of health, where priest-physicians managed patient care. Treatments included hydrotherapy, manual therapy, hygiene, diet, medications, and minor surgery. While not conclusively proven, these centers may have addressed less severe spinal disorders as part of their therapeutic practices.
Ancient Chinese medical practice within the framework of traditional Chinese medicine included techniques such as China massage and manual manipulation, posture and movement-based therapies resembling early forms of Qigong and herbal remedies aimed at strengthening bones and muscles. These conditions were understood as resulting from imbalance in Qi and dysfunction within organ systems that influence posture. Overall, it represented a holistic approach focused on restoring energy balance in the body.
Historical evidence suggests that in various ancient civilizations, spinal deformities were managed through a broad, integrative, holistic approach to care. Treatments commonly included dietary regulation, manual therapy such as spinal manipulation, massage, often using herbal or medicated oils, structured physical exercises resembling early forms of therapeutic gymnastics, and strengthening exercises, the use of medicinal preparations and traction techniques to help correct or stabilize spinal alignment. However, there is still no clear, reliable evidence confirming that these methods truly existed or were effectively practiced for the treatment of scoliosis per se.
Even though thoughts, views, and explanations differed, that is, mechanical, humoral, energy based, etc., it is heartening to observe that most systems in the ancient times shared a common idea, that is,
Treat the body as a connected system, not an isolated spine problem. This is an important observation and remains deeply relevant to contemporary clinical practice as well. However, the first clear medical description of the curved spine comes from ancient Greek medicine, especially the work of Hippocrates. He practiced medicine in the Asclepion of Kos. Hippocrates is traditionally identified as an individual Greek physician born around 460 BC on the island of Kos in Greece and is often referred to as the father of medicine. However, in historical and scholarly discussions, he is frequently considered within the broader context of the Hippocratic school and the collective authorship of the Hippocratic corpus. Hippocrates is traditionally credited with separating medicine from religious and magical explanations, shifting its foundation toward natural causes. He proposed that diseases arise from environmental influences, diet and lifestyle rather than divine punishment or superstition. This approach marked an important step toward viewing medicine as a rational and systematic field of study. Although some historians question whether all the teachings can be attributed to a single individual, it is generally agreed that the tradition is based on a real historical figure whose ideas were later developed and elaborated by his followers and students. The same scenario of authorship is applicable to most of the ancient texts in other parts of the world. This gap in evidence may also be attributed to poor preservation of the ancient texts, many of which were lost or destroyed due to natural disasters, fires, or wars. However, scholarly debate on this issue is still ongoing. Furthermore, the precise time frame in which these ancient texts were composed remains highly debated. While some historians support a particular period, others contest it, and no clear consensus exists in the literature. It is also likely that the practices described in these texts had been followed for thousands of years before they were eventually documented in writing, probably by students. This suggests that the medical knowledge itself predates the estimated period of the written manuscripts by a considerable margin. In ancient times, such knowledge was traditionally transmitted orally from teachers to students, who would later pass it on to subsequent generations. The need to document the precious knowledge as manuscripts was felt only later. Hippocratic writings broadly described nearly all forms of spinal curvature, including vertebral fractures with or without displacement of the vertebrae. However, when interpreted according to modern definition, the texts provide only limited information about scoliosis specifically.
Hippocrates identified two possible causes of spinal deformities: internal spinal abscesses, likely tuberculous in nature, and poor posture. He also noted that the positions patients habitually adopted while lying in bed could contribute to the condition. In discussing treatment, Hippocrates did not clearly differentiate between the various types of spinal curvatures such as scoliosis, kyphosis, kyphoscoliosis, and lordosis. As a result, the therapeutic methods described in his works were intended for a wide range of spinal deformities. He advocated the use of diet and traction in treating spinal deformities. Spinal manipulation was already commonly practiced during his era, but Hippocrates was the first to design devices that applied the principles of axial traction and three-point correction to straighten spinal curvatures and manage spinal diseases. Among the instruments he developed were the Hippocratic ladder and the Hippocratic scamnum or bench.
Although original Hippocratic texts contain no illustrations, depictions of these devices were later provided by Apollonius of Citium, who explained Hippocratic techniques in his commentary on articulations.
A device created by Hippocrates for correcting spinal deformities was the Hippocratic ladder. In this procedure, the patient was secured to a ladder and shaken, succussion, to help straighten the spine. Depending on the location of the spinal hump, the patient was positioned either upright when the deformity was closer to the neck or upside down when it was lower on the spine. Another apparatus known as the Hippocratic scamnum or bench was also used to treat spinal curvature. This method involved applying traction to stretch the spine while exerting focused manual pressure directly on the curved region. A third technique employed by Hippocrates was the use of a plank of wood. In this approach, one end of a wooden plank was fixed into an opening in the wall, while controlled pressure was applied to the affected spinal area using force manually at the opposite end of the plank.
Oribasius, another Greek physician, moved to Rome at the invitation of Emperor Julian. He improved Hippocrates' traction device by adding a crossbar that functioned as a lever, allowing forward pressure to be applied to a gibbous to help correct the deformity, while strong traction was maintained by turning the cranks. It should be acknowledged that in addition to the management of spinal deformities, the scamnum was also employed in the treatment of fracture of long bones and vertebrae and dislocation of joints, for instance the shoulder. Galen of Pergamum, another eminent Greek physician, authored numerous medical works, many of which analyze and expand on Hippocratic teachings. Much of his work builds upon and comments on the teachings found in Hippocratic corpus, expanding and refining earlier ideas. Within these writings, he included descriptions and interpretations of spinal deformities, offering further insight into their anatomy, possible causes, and treatment methods. Galen categorized spinal deformities into kyphosis, lordosis, scoliosis, kyphoscoliosis, and vertebral displacement without visible curvature. He pointed out that Hippocrates considered spinal deformities in general and felt the need to classify the various curvatures. He is believed to have coined the term scoliosis. These great physicians believed that such conditions result from tuberculosis, trauma, aging, and pain-related disorders. The more precise, modern understanding of scoliosis is typically attributed to Galen. Expanding on earlier Greek terms, he clearly differentiated scoliosis from kyphosis and lordosis. This structured terminology played a key role in shaping how spinal deformities are classified in contemporary medicine. The term scoliosis is derived from the Greek word skolios, meaning curved or crooked. Ibn Sina, widely known as Avicenna, was a leading Persian physician of the Islamic Golden Age and is considered one of the pioneers of medicine. He endorsed treatments involving stretching, pressure, and traction to address bone and joint deformities resulting from spinal curvature, similar to earlier Hippocratic methods. He also highlighted the role of dietary management in treating conditions such as spinal deformities. He has cautioned that spinal traction can be dangerous and may lead to paralysis or even be fatal. It is important to recognize that ancient Ayurvedic knowledge did not remain confined to the Indian subcontinent. Over time, key texts were translated into Arabic and later into Latin, allowing their ideas to travel across regions. This exchange of medical knowledge formed part of a broader global interaction in which scholars shared, adapted, and built upon one another's work. As a result, these contributions played a role in shaping the early foundations of medical practice across different parts of the world, influencing diverse healing traditions and systems. However, in many regions of the world, including India, religious and cultural beliefs limited practices such as human dissection, which in turn restricted the advancement of anatomical knowledge. Over time, repeated invasions, wars, fire, and natural disasters further disrupted established systems of learning and civilization. These events led to the destruction of institutions, loss of manuscripts, and a break in the continuity of medical and surgical traditions. As a result, what had once been a highly developed body of knowledge struggled to evolve, and significant portions of ancient medical wisdom were lost or remained underdeveloped.
In this context, it is noteworthy that Mukhopadhyaya conducted a systematic study of the extensive range of surgical instruments described in the ancient Susruta Samhita, documenting more than 120 tools and comparing them with those employed by the Greek, Roman, Arab, and modern European surgeons.
His analysis revealed remarkable similarities in the design, function, and classification of surgical instruments and related devices between ancient India and these other civilizations. This is a depiction of a fracture bed used by ancient Indian physicians for fracture and dislocation of the spinal column. Although these instruments reflect a shared global approach to treating comparable medical conditions, historical consensus reinforced by Mukhopadhyay's research generally recognizes Acharya Sushruta as having lived several centuries before Hippocrates. There is considerable historical evidence indicating that surgical practices were well established in ancient India. Yet, unlike the contemporary Greek and Roman civilizations, very few archaeological discoveries of surgical instruments have been found in the Indian subcontinent. An exception is highlighted in Dr. Naqvi's paper, which discusses the remarkable archaeological site of Taxila. Originally known as Takshashila, Taxila is regarded as one of the most significant archaeological locations in the region. Excavations there uncovered surgical instruments and other medical tools, confirming its role as an important center of medical learning in ancient times. Renowned physicians such as Atreya, Jivaka, and Charaka were closely linked with Taxila. The discovery of these surgical instruments provides clear and compelling evidence of the city's advanced tradition in surgical education and practice. Ancient Egyptians possessed surprisingly sophisticated clinical and practical understanding of spinal injuries, particularly their impact on movement and sensation. Among the most extraordinary surviving medical texts from ancient Egypt is the Edwin Smith Papyrus, dating to roughly the 17th century BCE, although the knowledge it contains is believed to originate from much earlier traditions. The Edwin Smith Papyrus contains some of the earliest recorded accounts of spinal trauma, including structured clinical assessment. Physicians were advised to carefully observe and examine patients by testing movement, sensation, and reactions to touch, reflecting an early awareness of neurological function. Cervical vertebral injuries. The text describes cervical compression fractures and connects them with symptoms such as paralysis, demonstrating recognition of the link between the spinal cord and motor function. Effects of spinal cord injury. Several cases explain that damage to the spinal column can result in loss of movement and sensation below the affected area, an impressively precise clinical insight for the time. Prognosis categories. Each case is classified into one of three outcomes: an ailment I will treat, an ailment I will contend with, an ailment not to be treated, essentially recognizing fatal or hopeless conditions. Treatment approaches. These include immobilization, especially for neck injuries, using bandages, wound care, and supportive management rather than invasive procedures. What's especially notable is how logical and evidence-driven this approach was for its era. The papyrus goes beyond simply prescribing treatments by outlining diagnosis, explaining the reason behind them, and describing likely outcomes, making it an early form of clinical case documentation. In the broader context of the history of medicine, this document shows that ancient Egyptian physicians had a surprisingly sophisticated understanding of trauma and neurological injury, well ahead of many later traditions that reverted to more mystical explanations. However, Specific information related to spinal deformities such as scoliosis is lacking in the papyrus. Erasistratus was a Greek anatomist who, together with Herophilus, founded a renowned anatomical school in Alexandria. Galen was later connected with this tradition. Unlike in Greece, the dissection of human cadavers was allowed in Alexandria, enabling Galen to significantly expand his understanding of anatomy during his studies there. Although trepanation was practiced from Neolithic times onward and as early as the time of Acharya Susruta, surgical intervention involving the spine and spinal cord remained largely unexplored. Due to the risks involved, conservative management of scoliosis remained the preferred approach for a long time. Crude methods of traction were slowly replaced by braces, exercise, and manual therapies. Hippocrates considered the possibility of surgically correcting severe spinal deformities, including using transabdominal anterior approaches to repair the vertebrae. However, no surviving writings describing these methods have been found. The history of scoliosis in ancient times shows that medical understanding was quite limited and often based on observation rather than scientific evidence. Early physicians recognized spinal deformities but lacked the knowledge and tools to accurately diagnose or treat them. Disorders of the spine and spinal cord were generally considered difficult and risky to manage, which discouraged attempts at surgical intervention. Over time, primitive traction methods began to evolve into more structured approaches, such as bracing, physical therapy, and surgery. These gradual developments laid the foundation for more advanced and effective treatments in later medical history. Let us briefly review some of the important clinical and diagnostic aspects relevant in scoliosis before exploring the evolution of braces, scoliosis-specific exercises, and surgical treatment methods. Taking a comprehensive history for scoliosis is essential to identify the probable underlying cause, categorize it, assess curve progression risk, and to have a rough idea of the most appropriate treatment path. Determine the reason for visit. It may be due to rib hump, uneven shoulders, or neurological symptoms. Age is critical for predicting the risk of curve progression. Curves typically progress faster during growth spurts. Any pain present should be clearly documented and described in detail, as it may help indicate the underlying cause. Pain that is disproportionate to the spinal deformity, occurs at night, or interferes with normal daily activities is considered atypical and may warrant a MRI evaluation. As for neurological red flags, numbness, paresthesia, weakness of the extremities, ataxia, other gait disturbances which may be due to leg length discrepancies, and bowel or bladder incontinence, warrant urgent workup and intervention. Any history suggestive of compromised cardiopulmonary function should be noted. Presence of cutaneous markers such as café au lait spots and hairy spots. Having 6 or more café au lait spots, that is larger than 1.5 centimeters for adults or 0.5 centimeters for children, is a key diagnostic criterion for neurofibromatosis 1. About 1 in 5 people with neurofibromatosis 1 develop scoliosis. A detailed family history regarding scoliosis should be obtained, as adolescent idiopathic scoliosis is known to have a genetic basis. Inquire about pre-existing conditions like Marfan syndrome, Ehlers-Danlos syndrome, cerebral palsy, or neurofibromatosis. We shall now review the principal features of the clinical examination of scoliosis. Uneven shoulders. Examine from the front and back. Direct visualization of asymmetry of waist crease, truncal shift and pelvic obliquity. Use of scoliometer. Assess the angle of trunk rotation for thoracic and lumbar prominence. Combine with Adams forward bend test. Presence of cutaneous markers for probable neurological and orthopedic lesions with a genetic basis. Plumb-line examination is an easy and simple method. The appearance and progression of secondary sexual characteristics serve as an approximate marker of skeletal maturity and should be considered during assessment. Assessment of gait, ataxia, leg length discrepancies, thorough neurological examination, abdominal reflexes, deep tendon reflexes, motor and sensory examination, presence of a positive Webinski sign, clonus, etc. Assessment of peripheral vascularity. Here are several key considerations in the radiological evaluation of scoliosis. Full spine series. 36-inch full cassette standing radiographs in PA with patient facing the film and lateral planes. Left and right lateral bending radiographs. For patients with a structural lumbar curve, lumbosacral bending radiographs. How to identify the stable and neutral vertebrae. The central sacral vertical line, CSVL, is a vertical line drawn through the center of the sacrum. The stable vertebra is the most proximal vertebra below the end vertebra that is most closely bisected by the CSVL. The neutral vertebra is the vertebra without rotational deformity and is identified on a coronal radiograph by the presence of symmetrical pedicles. Radiographic markers of skeletal maturity include rhizocine, triradiate cartilage, bone age assessment using hand X-rays. Curve detection refers to the orientation of the scoliotic curve. In idiopathic scoliosis, the most common pattern is a right-sided thoracic curve. A left thoracic curve is less typical and may suggest a non-idiopathic cause warranting additional evaluation. Shoulder balance is evaluated on radiographs to assess spinal alignment and overall balance before and after surgery. Pelvic obliquity is assessed to determine whether it results from a true leg length discrepancy, the scoliosis itself, or a combination of both. How to measure the Cobb angle? In the AP view, Cobb angles are measured from cranial end vertebra to caudal end vertebra. End vertebra is defined as the vertebra that is most tilted from the horizontal apical vertebra. For a given curve, the cranial end plate is used for the proximal end vertebra, while the caudal end plate is used for the distal end vertebra. The Cobb angle was first described in 1948 by the American orthopedic surgeon John R. Cobb. He fundamentally revolutionized scoliosis management through the formulation of the Cobb angle. Prior to Dr. Cobb's groundbreaking methodologies, the assessment and longitudinal monitoring of spinal deformities were predominantly conjectural. In contemporary clinical practice, therapeutic efficacy, whether pertaining to orthotic bracing, physiotherapeutic intervention, or surgical correction, is universally quantified through comparative analysis of baseline curb angle measurements over time. He critically reviewed the treatment methods for scoliosis outlined by prior pioneers in spine surgery and kept his own meticulous records of diagnosis, treatments, and radiographs. Cobb's work culminated in major contributions to spine surgery that are highly relevant to this day, including the Cobb angle and the Cobb periosteal elevator. The standard treatment for scoliosis until the 1920s was the plaster or turnbuckle brace, which patients would wear continuously during the developmental years in order to prevent the abnormal curvature from progressing. However, the 1930s saw the rise of five pioneering surgeons, Doctors John Cobb, Robert Lovett, Albert Brewster, Russell Hibbs, and Joseph Risser, whose unique contributions would make significant strides toward advancing the surgical care for patients with scoliosis. During this time, spinal fusion following plaster casting became the gold standard to correct and prevent further progression of the scoliotic curve. Let us now examine the limitations of curb angle measurement. Classically, the curb angle has been the gold standard for assessing spine curvatures both in the sagittal and coronal planes. However, it provides only two-dimensional information about a three-dimensional spine problem, hence failing to account for vertebral rotation. A measurement error of 5 degrees is widely recognized for both intra-observer and inter-observer variation. Rotation. Even the slight increments in patient rotation between examinations can markedly affect measurements, with variations reaching up to 20 degrees. Therefore, maintaining consistent positioning is essential. Diurnal variation. In the same patient, spinal curvature may increase over the course of a single day, with variations of approximately 5 degrees. Overall, despite the limitations noted above, a change in curb angle exceeding 10 degrees is 95% likely to reflect a true difference.
Several radiographic alternatives to curb angle measurement are available when X-rays are necessary, but the curb method proves inadequate or yields inconsistent results.
The management of idiopathic scoliosis is largely guided by the magnitude of spinal curvature, making its accurate angle measurement a critical component of clinical assessment to decide about conservative or surgical pathways. Although the curb angle remains the gold standard for quantifying scoliotic spinal deformity, several alternative radiographic techniques have been proposed. In a comparative study, Wilinski et al. Evaluated the Cobb, Ferguson, and the centroid methods, the latter of which estimates curvature using the vertebral centroid angle based on determining the geometric center of vertebrae. Their findings demonstrated that the Cobb method exhibited the highest inter- and intra-rated reliability and could be applied consistently even by novice assessors. In contrast, although the Ferguson and centroid methods have been reported in the literature to achieve high intra-class correlation coefficients, a statistical measure of reliability, their accurate replication generally requires greater examiner experience and expertise. AI platforms and deep learning architectures. In contemporary clinical practice and research, highly specialized neural network architectures are increasingly employed to automate spinal image analysis. Instead of requiring radiologists to manually place multiple reference points on each vertebra for centroid determination, AI-based systems can perform vertebral segmentation and landmark identification rapidly and automatically. Mobile and web-based edge computing platforms now enable clinicians to capture radiographic images using smartphone cameras. Integrated artificial intelligence algorithms can then automatically identify the apical vertebra, map vertebral coordinates, and rapidly generate calculated curve angles. In 1992, Joe Chapok was awarded the Nobel Prize for the development of an innovative gaseous particle detector that enabled the conversion of photons into electrons through exposure to a pressurized gas such as xenon. This technology amplified proton detection efficiency while substantially reducing radiation exposure, and subsequent refinements of this system ultimately led to the development of the EOS imaging system. Low radiation imaging. EOS imaging systems provide 3D spine views with significantly less radiation than traditional X-rays. This is especially important for children who need regular monitoring over many years. According to this study, axial rotation measured by EOS is an accurate representation of rotational deformity in the non-instrumented AIS spine. They observed only minor differences in relative vertebral rotation difference (VRD) in the proximal thoracic spine. Clinical and non-radiographic alternatives to curve angle measurement. Advantage of these methods is avoidance of radiation exposure. Scoliometer. As previously discussed, the scoliometer is useful for monitoring trunk asymmetry during clinical evaluation. However, it does not provide a direct assessment of the underlying spinal curvature. Spinal mouse. The spinal mouse is a handheld sensor-based electronic device that is guided along the surface of the back to evaluate spinal alignment and curvature. Studies have demonstrated good correlation with the radiographic parameters and is particularly valuable in the assessment of scoliosis while avoiding radiation exposure. Moire topography and surface topography. These techniques employ light projection and optical surface scanning to generate a three-dimensional representation of the back contour. They allow detection of asymmetry without ionizing radiation, making them well suited for repeated follow-up examinations. Nevertheless, these methods assess external surface morphology rather than the underlying osseous structures directly. So these methods cannot be stated as substitute for radiography. This table provides an overview of the key advantages and disadvantages of the most frequently used methods for assessing scoliosis. Emerging screening technologies. Modern 3D ultrasound imaging. Modern 3D ultrasound imaging is gaining popularity for assessing structural changes in the spine due to several advantages. It is non-ionizing, cost-effective, user-friendly, and can be performed while the patient is standing upright. However, because ultrasound waves cannot penetrate bone, it has limitations in accurately determining the severity of spinal curvature. Recent developments in freehand 3D ultrasound technology have helped address some of these challenges by integrating conventional 1D array ultrasound probes with positional transducers, enabling the reconstruction and visualization of spinal anatomical structures in three-dimensional space. Raster topography with automatic image analysis. Recent advancements in computer technology have facilitated the development of raster topography techniques incorporating automated image analysis, commonly referred to as raster stereophotography. This method enables the assessment of three-dimensional spinal deformities by examining the topography of the dorsal body surface, utilizing the principle of optical triangulation to reconstruct the spine and the trunk in three-dimensional space. Dyer's Formetric 4D. The Dyer's Formetric 4D, a surface topography system, has emerged as a valuable tool for the assessment of posture and spinal deformities owing to its non-invasive, non-contact and radiation-free characteristics. It enables comprehensive visualization of postural changes without exposing patients to ionizing radiation. During a static standing posture assessment, the system requires only approximately 6 seconds to acquire a complete scan of the back. The device integrates a digital camera and a projector which project a structured light pattern onto the patient's back surface. The captured data are instantly transmitted to a computer where specialized software reconstructs a three-dimensional digital representation of the examined region. This automated process minimizes operator-dependent errors and enhances measurement reliability. Owing to its accessibility, safety and efficiency, the Dyer's Formetric 4D serves as an effective alternative to more invasive diagnostic procedures and is particularly useful for evaluating postural status both before and immediately after therapeutic interventions. Furthermore, the system provides highly accurate measurements and enables clinicians to analyze spinal and postural parameters in a realistic and near real-time manner, thereby supporting informed clinical decision making. However, each assessment modality possesses distinct strengths and limitations. While highly accurate imaging techniques such as radiography, computed tomography, MRI, etc. remain essential at critical stages of diagnosis, particularly when precise evaluation, surgical decision making, or treatment planning is required, emerging technologies offer valuable complementary applications. These newer non-invasive methods are particularly well suited for scoliosis screening, longitudinal patient monitoring, and routine clinical evaluation, thereby reducing the need for repeated exposure to ionizing radiation while supporting ongoing assessment of spinal deformities. Artificial intelligence is playing an increasingly important role in the management of scoliosis by improving the accuracy, speed, and reproducibility of spinal assessment, thereby assisting clinicians in diagnosis, treatment planning, and follow-up evaluation. It is imperative that physicians should possess a basic understanding of AI and its applications. Nevertheless, clinical judgment, compassion, dedication, kindness, and the ability to inspire hope remain fundamental, especially as many distinguished individuals throughout history from ancient to modern times are believed to have lived successful lives despite scoliosis, reflecting the timeless teachings of the ancient physicians that where there is love for humanity, there is also love for the art of healing.
This video has gotten quite long, so I will cover the rest of this interesting topic in the upcoming videos that will be uploaded soon. Thank you so much for watching. Goodbye.